If you have been finding it hard understanding what the anatomy of the diaphragm is, or you have been studying about the diaphragm and you seem to not even get it at all, stay to the end of this video because I'll be explaining the diaphragm thoroughly with basic mnemonics so that even in your sleep you understand it. If you are new to my channel, make sure to subscribe and turn on your post notification button so that anytime I drop any video you'll be sure to be notified. I remain your great science tutor Lorenzo, so let us jump right into the video. So we'll be talking and explaining about the diaphragm with these following outlines. We'll introduce the diaphragm, we'll talk about where it originates, where it inserts, major and minor openings around the diaphragm. We'll talk about the blood supply to the diaphragm, the nerve supply to the diaphragm, its lymphatic drainage, talk about the mechanism of action, what is the action of the diaphragm, and lastly we'll attach a clinical relevance to the diaphragm so that you understand the diaphragm holistically. So let us start with the introduction. The first question we'll ask ourselves is, what is the diaphragm? What is the diaphragm? The diaphragm is a large dome-shaped flat muscle that separates the thoracic cavity from the abdominal cavity. That is why it is called the thoraco-abdominal diaphragm or the thoraco-abdominal muscle. So it is a large dome-shaped flat muscle that separates the thoracic cavity from the abdominal cavity. Now, you should understand that it closes the thoracic outlet. It closes the thoracic outlet, and it is a primary muscle for respiration. It is a primary muscle for respiration. That means it contains two parts. One, a peripheral muscular part and a central fibrous part called the central tendon. The next outline we're treating here is the origin of the diaphragm. Just like every muscle, diaphragm is a wide muscle. It's a very wide muscle, but it has an origin. And so what is the origin here? The origin of the diaphragm is basically three parts, because it's a very wide muscle. So it's originating from the front, which is the sternal part, at the back the vertebral part, and by the side the costal part. In the sternal part is originating from the posterior surface of the xiphoid process of the sternum. The posterior surface of the xiphoid process of the sternum, because the xiphoid process has three parts, which it marks a origin for three basic muscle. In front is the rectus abdominis, at the tip the linea alba, and at the back the center part of the diaphragm. By the side is the costal part, and the costal part originating from what? The lower six costal cartilages and the ribs. The lower six costal cartilages and the rib. So don't forget that. At the back, the vertebral part is originating from two basic structures, the crura and the arcuate. So we have the right and left crura, and we have 5 arcuate ligaments. So the right and left crura, the right crura spans from L1 to L3 vertebrae and their corresponding intervertebral discs, while left crura spans from L1 to L2 vertebrae and their corresponding intervertebral discs. Don't forget. The right and left crura are what? United or are joined together by what? Median arcuate ligament. So don't forget, I told you there are 5 arcuate ligaments. So the right and left crura are joined by what we call the median arcuate ligament. So remember, the right crura comes from L1 to what? L3, while the left crura is from L1 to L2. So they are united at T12 at the median arcuate ligament. Oh no, now you also have at the right and the left, you have what we call the lateral arcuate and the medial arcuate ligament. You have the lateral and the medial arcuate ligament. So don't forget. Oh yeah, the medial arcuate comes from the body of L2 to the transverse process of L1. Don't forget. The medial arcuate is from the body of L2 to the transverse process of what? L1. While the lateral arcuate is from the transverse process of L1 to what? Under the surface or the ribs of what? T12. Don't forget. So that is the medial and the lateral arcuate ligament. They are very, very important structure. Don't forget it. All the muscle fibers from the sternum, costal, and vertebra converges at the central tendon and insert along its margin. So all fibers we discuss from all the 3 origins insert on the central tendon, along the margin of the central tendon. So the central tendon, do you know, it is a trifoliate shaped structure, which means it has an anterior central part and it has 2, the right and the left posterior part, leaflet. They are all leaflets, so that's why we call them trifoliate leaflet. So now these 3 parts, the anterior part and the posterior part, this posterior part has a right part and a left part. The right part is what? Short and stout, while the left part is thin and long. Also, you have to know that this central tendon is closer to the sternum than the vertebrate. It's closer to the sternum than the vertebrate. And one thing you have to understand that it is inseparable from the fibrous pericardium. So one thing you have to understand that after it's originating from the sternum, costa and vertebral part, they all insert on the central tendon. And the central tendon has an anterior and a posterior leaflet. The next we'll be talking about is the major opening of the diaphragm, or the major opening in the diaphragm. We'll be talking about the major opening in the diaphragm. So the first opening we'll be talking about is the cava opening. The cava opening is where at the right posterior leaflet of the central tendon, and it is what, square or quadrangular in shape. We have the esophageal opening, which is what, at the peripheral muscular part close to the what, left posterior leaflet, and it is what, round or oval in shape. The last one is the aortic opening at the back of the diaphragm, which is what, which is circular in shape, and we call it the what, the aortic opening. It's at T12. So T8 for cava opening, T10 for esophageal opening, while T12 for what, aortic opening. So what transmit through this opening? The first one is what, at the cava opening you have the IVC and the right phrenic nerve. At the esophageal opening you have the esophagus, which is the major part there, the right and left vagus trunk, and the esophageal branch of the left gastric artery. Don't forget. At the aortic opening you have three basic structure also. You have what, the thoracic duct, the descending aorta, and the azygos vein. Now, other minor openings to the diaphragm include, so we have minor openings. We have talked about the major opening, which is the vena cava opening, which is the esophageal opening, and you have the aortic opening. So the next is the minor openings. What are the minor openings in the diaphragm? We have between the xiphoid process and the what, seventh costal cartilage, and what is it? Is the foramen of Larry. The foramen of Larry transmits what, the superior epigastric vessel. Between the seventh and the eighth rib transmit what we call the musculophrenic artery. Don't forget, between the seventh and the eighth rib transmit the musculophrenic artery. Between the seventh and the 11th rib transmit the lower 5 intercostal nerve and vessel. Between the 7th and the 11th rib, the intercostal nerve and vessel, lower 5 intercostal nerve and vessel. Also, in deep to the lateral arcuate ligament transmit the subcostal nerve and vessel. Do you get it now? Then while deep to the medial arcuate ligament transmit the what, sympathetic chain. The course of the diaphragm is pierced by what? The greater, lesser, and the least splanchic nerve. Why the left course of the diaphragm is transmit the hemiazygos vein. Next, we'll be talking about the blood supply to the diaphragm. So when I say the blood supply to the diaphragm, I'll be mentioning the arteries. So when I mention the arteries, you should also know that is a corresponding vein too. So the arteries is also the same thing as the corresponding vein. So the first one is the superior phrenic artery. The superior phrenic artery is a branch of the what? Of the descending aorta, which is the thoracic aorta. While the inferior phrenic artery is a branch of the abdominal aorta. So the thoracic aorta, which is the descending aorta, passes through the what, aortic opening and becomes the what, abdominal aorta. The pericardiophonic artery is a branch of the internal thoracic artery. It supplies the pericardium and also the diaphragm. The next is the musculophrenic artery. The musculophrenic artery is a terminal branch of the what, internal thoracic artery. The next one is the what, a superior epigastric artery. The superior epigastric artery is a continuation of the internal thoracic artery. You also have the intercostal or the lower 5 intercostal arteries and the subcostal arteries. The lower 5 intercostal arteries and the subcostal arteries. So we're talking about the nerve supply to the diaphragm, because that is how the brain communicates with the diaphragm through these nerves. Because without the nerve, the brain cannot send what, neuronal transmission, or there will be absence of neuronal transmission between the brain and the diaphragm, which will cause paralysis of the diaphragm. So what are the nerves? You have the right and left phrenic nerve. The right and left phrenic nerve, which is a branch of the cervical plexus. They supply the right and left half of the diaphragm. We have the lower 5 intercostal nerve and subcostal nerve. The lower 5 intercostal nerve and subcostal nerve, they supply the peripheral part of the diaphragm. The right and left phrenic nerve supplies the right and left half of the diaphragm, close to the esophageal region, while the lower 5 intercostal nerve and the subcostal nerve supply the peripheral part of the diaphragm. The lymph of the diaphragm are drained to 4 basic nodes. The first one is the anterior diaphragmatic lymph nodes, the posterior diaphragmatic lymph nodes, and the right and left lateral diaphragmatic lymph nodes. The anterior diaphragmatic lymph node is located close to the xiphoid process. The posterior diaphragmatic lymph node is close to the aortic opening. The right lateral diaphragmatic lymph node is close to the cava opening, while the left diaphragmatic lymph node is close to the aortic opening. These are the lymphatic drainage, or the lymph node drainage of the diaphragm. So what are the actions to the diaphragm? So simply, based on what we have just said, what are the actions? What is the work of the diaphragm? First of all, diaphragm is what we call a primary respiratory muscle. So during inspiration, when you inspire, when you take in air, what happens? There's a negative interpleural pressure. So if there's a negative interpleural pressure, drawing air into the lungs, what will happen? The diaphragm will descend, increasing the vertical diameter. So the diaphragm will descend and become flattened, thereby decreasing interthoracic pressure, increasing negative interpleural pressure, and increasing intra-abdominal pressure. So when you increase intra-abdominal pressure, what happens is assisting defecation. So when you increase intra-abdominal pressure, you could expel all the GIT content out. When you increase intra-abdominal pressure, also you urinate when you increase intra-abdominal pressure, you defecate when you increase intra-abdominal pressure. Don't forget. So when you drop the interthoracic pressure, there will be an increase in negative interpleural pressure, which will draw air inside. Do you get it? Don't forget that. Also, it also assists in weightlifting by closing the glottis to assist weightlifters to carry high amount of weight by stabilizing the vertebral column. Diaphragm opening, it's when the contraction of the diaphragm occurs during inspiration, it increases venous return into the right heart. It increases venous return into the right heart. It doesn't have an effect in the aortic opening, because if the aorta was passing through the diaphragm, contraction of the diaphragm will close the aorta, inhibiting blood flow to the lower extremities. Don't forget that. But in the aortic opening, it is very good because it acts as a lower esophageal sphincter, preventing regurgitation of food that has entered into the stomach. Very simple. Yes, what is the clinical relevance of the diaphragm? Remember, I said that the diaphragm is a primary muscle of respiration, which means the diaphragm needs to be contracted. The diaphragm needs to be contracted for respiration to occur, because it's the principal inspiratory muscle. It is the principal inspiratory muscle together with the external intercostal muscle. It's the principal inspiratory muscle together with the external intercostal muscle. So therefore, when there is paralysis of the diaphragm caused by the damage or the lesion to the phrenic nerve, so when there is a lesion to the phrenic nerve, what will happen? The diaphragm will not contract, which will cause a decrease in respiration, which will also accompany with drop in oxygen. And when there's a drop in oxygen, what will happen? It will be very, very hazardous to our blood, because our blood needs oxygen and our body needs oxygen. So it could cause brain death, it could cause tissue damage, and a whole lot. The next is hiccup. So you might be feeling hiccup sometimes, and hiccup can be normal or it can be pathological. So the hiccup is just an involuntary spasmodic contraction of the diaphragm, which is accompanied with the closure of the glottis. You get it now? And it's usually as a result of eating or drinking. When you are eating or drinking, it can cause irritation to the phrenic nerve or the diaphragm. So when it causes irritation to the phrenic nerve or the diaphragm will start contracting uncontrollably, and the glottis will start closing. So that's why you have that feeling. So it can also be caused by hysteria or uremia. So all these are normal signs, and all these, but when it is pathological, when it is secondary to a disease that is occurring in the body. So the first one I'll talk about is a diaphragmatic paralysis, when there's a unilateral or bilateral damage to the phrenic nerve, or hiccup. Don't forget that. So we have come to the end of this lecture series on the diaphragm. So hope it all made sense, and I hope you understand about what we talked about in the introduction, the origin of the diaphragm, the insertion of the diaphragm, the major and minor openings of the diaphragm, the blood supply, the nerve supply, the lymphatic drainage, the action, and the clinical correlation. I hope it all made sense. So please, if you are just new to my channel, make sure to subscribe and turn on your post notification button, so that anytime I drop any content or any video, you'll be sure to be notified. And if you have any issue with any of the topics, or you want me to make a video for you, please drop it down in the comment section. When I come, I'll read it and make the video for you. So now, see you in the next class.